Thank you very much. We'll just dive straight into the last presentation for the day. Rashad, you have the floor.
Thank you very much. First of all, just introducing myself. My name is Rashad Massoud. I'm the Chief Medical and Quality Officer for a university research company. In that capacity, I also run the largest project that we have within the company, which is USAID's Applying Science to Strengthen and Improve Systems project. This is a global project which, up till recent days, operated in 30 countries around the world, addressing the improvement in the global health priorities for the US government. I've been in the field long enough that one thing I want to start off with is to talk about the whole idea that Kelly initiated, which is going from simple improvements, she used waiting times as the example, to clinical improvements where we've seen improvements in outcomes and proxy outcomes, and then moving towards this whole notion of improving systems of care. And I think what we're hearing is something that we have seen over the years, and I think Jim could attest more to that, that there's been a large evolution in the application of modern improvement methods in healthcare in such a way that now we're not just looking at individual processes, we're looking at collections of processes that together yield important outcomes. And I think added to that mix is this whole notion of does everybody have access to those systems? Have we set up the finances in such a way that people have financial access and there's enough coverage at the right sort of quality of care, etc.? And this sort of, once we start to think of it this way, it goes into the health reform agenda. It becomes improvement, becomes integral to a much larger health system strengthening health reform agenda. And I think this is where I'm seeing at least things going into the future. Now, at the heart of this are the very frameworks and principles that Pierre and Joe talked about. Without those, I don't know that we can move in further and further, and they become much more important as we go along. On their own, without the policy and the finance, governance aspects of a health system, we wouldn't be able to achieve the results that we need at scale. So that's the sort of direction in which I am seeing things going, at least in the global health arena, and I'm sure they apply not only in low and middle income countries, but in other countries as well. That's the first point I wanted to bring up in listening to the conversation today. The second point is this whole notion of, do we know what works? I think there's two parts, at least for me, there are two parts to it. And in a way, they were presented by one of the frameworks that Kelly showed, but there's the science, there's what works. And then there's how do we make that science, how do we make that evidence-based intervention that we have happen reliably for every patient, every client who needs it, every time it's needed. And that's the whole idea of the implementation improvement that is there. I believe that one of the big issues that we have is that we know so much that can save lives, that can alleviate suffering, that is not actually reaching the patients who need them, the people who need them. And if we can bridge that gap, we would do a lot of good and we would improve care for so many people that can benefit from it. The third point is that it's not just about the science and the delivery of that science, it's also highly dependent on the context. And I really liked your graph when, it's not just inputs, processes, outcomes, it's inputs, processes, context, outcomes. Context is key. Just to give you, this has been a big topic of conversation in the last few years for us. And I just came back from the ISQA meeting where a colleague of mine was presenting some early results where she was able to show that 2/3 of the intervention that worked could be attributed to the context rather than the clinical intervention itself. Now, few people think of that, and I think that's really important because as we start to understand how improvement works and why it works and how can we make it successful and how can we generalize it elsewhere, we really need to understand the effect of the context in it. And I do believe that this is an area that, at least going forward, we need to be looking at much more critically than we've done in the past. Another point that came up is the whole idea of, uh, is the work sustainable? And and yes, Nana, we've had many places where we've gone back years after, we've evaluated. Invariably, if it's done right, if this is implemented in a way that is contextually appropriate, that is, it involved the right people, it involved the leadership, it was instituted within the everyday operations of the work, etc., why would people go back to a worse way of operating? They just don't. I mean, that's not the nature of people. So if you do it right, yes, it generally is sustained, and we've got result after result, study after study that we have done where we've gone back years after to look at what have we accomplished, and we found that pretty much done right, it stays. But there's another notion here, which is not just is what we did still there years after? Have we enabled the host country, and I'm speaking now from the point of view of somebody who goes to help a country, have we instituted the capability in that system that we've worked with to be able to do the work or similar work to what we've done with them independent of us in the future? That is, if we work with them on HIV/AIDS and we got great results and those results are sustained, has that same system been able to take that capability from HIV/AIDS and use it in MCH, for example, independent of technical assistance from us? And that, to me, is the hallmark of, have we instituted improvement as a means of doing work? And I think that's a very important notion. If we're talking about improvement in the global health arena, that's a really key notion to be looking at. Um, the whole idea of improvement being treated as if it's a technical exercise, in my opinion, it just isn't. I mean, there is technique, there's a lot of science to it, and there's a lot of methods, etc., which are all fine. But if we treat it as if it's a technical exercise, the likelihood is it probably won't go very far. It is a complex social intervention in addition to being a technical intervention. And it's not just about appealing to people's minds. It's not about convincing them that this is important. It's also touching their value system. It's getting them engaged in it in a way. The whole empowerment thing that Joe described, that is of the essence. I've not seen things happen when people were not engaged in the way that they should be. That empowerment, releasing the energy, that is critical to making this happen. Now, I don't want to put it in the realm of something that's sort of like totally unmeasurable or anything, but it definitely does include all those components combined, and we need to be looking at them, and we need to be cognizant of the fact that it's not just a technical exercise. Measurement was mentioned, and I just want to point out, but I'm not trying to address it, Nana spoke enough about it, but there's one more point that I would like to add to measurement, and that point is the following. There may be some great ways of saying, have we improved quality, and we may be able to standardize them, and I would very much look forward to that, and there's several people looking at that. But I would want to urge against the notion that this be done at the expense of the extremely important part of conducting the improvement, which is people who are on the improvement teams themselves, collecting their own data on a regular daily basis, plotting their data, making changes, looking at the effects of changes on a daily basis. That is the heart of improvement. And I think when I hear people talk about measurement, this is almost being said in contrast to and almost at the expense of the importance of improvement teams who collect their own data on a regular basis, introduce changes, look at the effects of those changes on the data that is the heart of improvement. And whatever we do on measurement, we should not undermine the extreme importance of the improvement as it happens and data collection on a regular basis by team members who are improving care in doing that. One of the things I want to point out, and it's notice that neither Pierre nor Joe actually mentioned the name of a method. And I think it's that this is really critical. This field and in the global health arena is full of jargon. There are papers and papers written about this, and I have to tell you my own experience. I've gone to ministries of health. My project used to be the Healthcare Improvement Project. I used to direct it. I went in. I remember talking to the permanent secretary. I introduced myself, director of the Healthcare Improvement Project, and the first reaction was healthcare improvement, quality improvement, performance improvement. What's the difference? I think I've been on a mission about this, and I will put a pitch here because I think in the global report we really need to be stopping this confusion that is happening in the field. There is so much confusion about this, and all it takes is one person to put a little twist on a method or an approach or something, and they call it their own, and then we get into this whole thing about I do it this way or I use this method versus that method. I've been in ministries of health where because the names are different, you've got two teams, two groups that don't even talk to each other, don't recognize that they're trying to accomplish the same thing. I see a lot of heads nodding. Please, this is really important to put. There's a beautiful article by Kerry Ann Walsh from Manchester University called Pseudo Innovation. If you haven't read it, please do. It really describes it. It's a very important thing, and it is a problem in our field we need to address. The last thing that I'd like to talk about is something that didn't come up, but I feel it's important to bring up because this is something that we've been trying to grapple with in the field, and it's the whole notion of how can we truly so you've seen the results. I think Joe showed some of Nana's results, lots of graphs, and Pierre had several of them. These are the results that we all use. We basically plot data over time, and we introduce changes, and we look to see the effects of those changes, and we say, this is how much we've achieved. I've got tons of those, one after the other. There's just it's an endless number of charts of that sort that we have from our work. I've been asked the questions, and they've come up here in previous sessions. How do you know that these results are only due to what you've done? How do you know that you can claim them? We've been on a mission trying to solve that problem, and of course, the thing that happens is they say, well, you haven't run an RCT. This is not good enough to prove that you've improved, to show that you've improved care. Well, first of all, I think that there may be value there, but Ashish is nodding his head. We spent a whole week together trying to solve this problem. There are other ways by which we can attribute the results we're getting to the changes that we are making. And they don't have to be as time-consuming or as costly, and they can be good enough to show what we're doing. At the heart of those approaches, and some of them are wave sequence, stepped wedge designs and others that we could use. But at the heart of those is the whole notion that what we can't do is come in and say, because it worked this way in that particular setting, let us just use that set of changes that happened in one place and try and generalize it everywhere else. And lo and behold, we're not going to be able to get the same results or anything like those results because that context is different. Probably even the same context at a different time is going to operate differently. Within the same country, you're going to find different settings. So the whole nature of improvement is one, contextual, and by controlling all of that, we have eliminated the biggest player, which is context. And the second part is that it's iterative. That is, improvement is about continuous learning on a daily basis through testing different changes. If we try to control any of that and not feed it back into the system right away, the likelihood of success is going to be very limited. And this, I think, is an important thing to bring in, because for me, this report that comes out of this committee is going to take us into the future. And I think issues like these about how can we truly attribute without inhibiting the very nature of improvement, that it is contextual and it is iterative, is at the heart of what we should be talking about going into the future. I can say a lot more, but I know that time is coming up and I should probably stop, but I'm happy to engage more either today or on future occasions. Thank you.